Okay, welcome everybody to Theatre Avan here. So the next 45 minutes, we're going to have a session about vascular access and vascular closure in general, but also very much focused also on the suture-based vascular closure. What are the important key steps and learnings there? So I have an esteemed panel here with me. I have Dejan as a good friend. I have Maurizio as well, Maurizio Taranvaso, and we have Wolfram Vulker also here as a discussant. So maybe before we start really kick off on the session, I'm going to show you the session objectives. So it's kind of three parts. First, to demonstrate and educate how to use both CT and also echo guidance to achieve optimal vascular access. So that's really all about purely focused access, how to do this state-of-the-art in contemporary practice. Secondly, to show the steps of vascular closure with the suture-mediated vascular closure device, so specifically focused on Procedural, how to deploy it and how to use it. And then the last part is how to we will discuss the challenges and solutions in achieving optimal suture-mediated vascular closure. So really, what are the steps to do the good vascular closure with these suture-mediated closure devices, and also, if you have time, some maybe challenging cases or some how to catch on complications. Yes, that's also how to bail out ourselves. So I'm going to give the word now to Dejan. Yes.
Thank you very much, Ole. So one question before we start further, which I think is relevant, and that is, how many of you routinely use suture-mediated closure? And I know that Theatre Havan is problematic because it's a bit dark, but it's actually less than 30%, I would say. So most of the people present are going to start using it, I guess. So one of the important points when starting using it, of course, is to know the steps, how to perform suture-mediated vessel closure. So of course, you can go to YouTube, and you can see these kinds of videos where you have these steps, and it's important to keep an overview of the steps. So the first is positioning the device inside the artery, and we are going to talk about this a lot, what is important in that respect. Second is to try to deploy it correctly. And you saw the first step with deploying it with the plunger. Then the second step here is to puncture the artery. You see number 2 on the Procedural. Then number 3 is to pull it up, and then number 4, as you will see, is to get the plunger down again, to get the knob down again, advance a little bit the system inside the artery, and then pull it out. So those are the 4 steps that you actually have already on the device, but we already see a bigger picture, positioning inside the artery, puncturing the arterial wall, and these were the sub-steps. And then, of course, exchanging the systems on the wire. You can close with 2 Procedural. You, of course, can have the wire always as a bailout, which is a convenient part of the system. And that also is a separate step, so never forget about that. Never pull out the system without putting the wire back in, because the wire is your safety, of course. And then number 4 is finishing the procedure by tying the knots. You will see here a second device put in, where you turn it a little bit to the other side at 30 degrees. The first one was 30 degrees left, the second one is 30 degrees right. And then you repeat, of course, all the steps. After you're done with that, you perform your TAVI or other procedures that require large bores, and then you finish with tying the knots. The question is this enough? Is it enough to know these steps that you can actually find on YouTube, quite frankly? Our belief that it's not enough, and this is why this session has been designed. We think that what's in the middle is very important. You need to know on the model and always in your mind what the steps are. You need to know the 4 steps of puncturing the arterial wall correctly. You need to know the 4 concepts of positioning inside the artery, puncturing the arterial wall, exchanging all the systems of the wire, including a second Procedural, and of course tying the knots. But you also need to know what's to the left and to the right of it. You need to know how to perform a good puncture of the femoral artery initially. You need to be familiar with the baseline anatomy so that you can succeed in deploying the system correctly. And at the end, you need to be very familiar with what you leave in the patient. What is your final result in the periphery? And for that, you need to make sure before tying the knots, pulling the wire out, that is always your safety. So we will speak about all these aspects as a bigger picture. We'll start with the baseline anatomy. So Oleg, can you tell us what is the best way to have a safe puncture so that our suture-mediated vessel closure will be successful?
No, thank you. That's indeed a good introduction. So this is kind of the YouTube or TikTok video, you know, about how to do it. And it looks very easy, but I think we have to indeed put it in a bit bigger context. If you want to go for a successful access and closure, there's many more finesses and aspects to consider. And that's hopefully we can show you in this whole session. So it starts first with a good access, yes? And indeed, what do I understand on a good access? Well, this is, again, it frames into a bigger context. So it first starts already with a CT. We all have CT, so this is in the context of TAVI. If we do the TAVI, we have typically a good CT. And you see already, I start by looking in general how tortuous is it. I also turn my model. I want to see where is my horizontal part, where is the part where it dives into more profundo, because I want to absolutely avoid a too high puncture as well, because you can definitely make a puncture in the diving part of your artery. You can have access, but at the end, you will have problems with your closure. So then that's one thing. The second thing is you walk through it. You want to see if you have roughly more than 5 millimeter. For most of the TAVI devices, a 5 millimeter diameter, intraluminal diameter, how much there's calcification. You screen for this up front, pre-procedurally. You look at that on the CT. Here, for example, there's a little bit of calcium here, but the size is definitely big enough. It's 6.3 millimeter. That's no issue whatsoever. I keep on scrolling down. So that's just for the access in the iliacs. But then also the puncture side is extremely important. I take my minute, I would say, to really scroll there around that puncture site and really make a reflection of, oh, be careful. Here, for example, I see almost like a circumferential calcification, 360 degrees, almost at the spot where I would consider making, or just above my puncture site. So this is not ideal to me, yes? I want to find a calcium-free spot, which is in the zone of the femur head, and which is still a centimeter minimum above the femoral bifurcation. So right side, I'm not super happy. There is some calcium-free spot, but immediately above my puncture site, there is a circumferential 360-degree calcium. So I also inspect for the left side. I do the same exercise. I start from the aorta, the common iliac, external iliac. Looks all pretty acceptable. Nothing impossible there. And then I'm going down here, I'm approaching the puncture site. I see there's still a little bit of calcium, but not that same circumferential 360-degree calcium as on the right side. I see a good diameter, intraluminal diameter. And then I think, well, this is maybe where is the bifurcation here. That's kind of bottom femur head. That's very important to know, that you stay at least a centimeter above. And this reference, you can either, if you use some fluoro still for your puncture, you can do that, but I would always advocate to use echo as well. But this gives you a good idea where to puncture, that the left side is probably the better side to go. So CT, I see many people starting doing a TAVI without even, they look very much to their CT just for the valve, but they they have a very quick view, almost only just at this view for the access. I spend more time, to be honest, and I really inspect my puncture site and try to find out what would be my best puncture site. So you get this information almost for free on your CT. That's what I demonstrate here. So we inspect this. I turn this model. So the point I wanted to make is that you can definitely make a puncture here, for example, but that's already in the diving part. And I've seen typically if you have a failure of your pro style, it can be multiple reasons, but one of the big reasons is because you puncture actually in the diving part of your artery. So you should stay away from that. Here, it's a nice patient with a very low femoral bifurcation. Right side, there is some circumferential calcification there, so I want to avoid. But here, I could say, well, I'm going to puncture mid-femur head. So that's my study on my CT. Right side, there's some things I exclude. Left side looks better. Femoral bifurcation is bottom femur head. So let's go for just 2 centimeters. I have the margin to go 2 centimeters above mid femur head. That's going to be my puncture site. And that information I take with me in the cath lab. On top of that, I take more information in the cath lab because I am prepared, or at least the fellows are prepared, to write down also the size of the balloon and stent if I would run into a problem. So this is not something we go to inspect when we have the catastrophe and the problem in the lab. No, this information we take on a paper, we make a note. Well, okay, if we need a balloon, we're gonna use a 7mm balloon, we're gonna use a 9mm covered stent. That is ready. We have that information with us, and very often this material is already laying ready on the site. We don't unpack it, of course, but in case, which is luckily rare, but we have it. So then I think for the access, that's enough about CT. Then if we look for the echo, and I think this is contemporary practice again, we should be using echo. I mean, I think it's not contemporary anymore to do just a fluoro-guided or even worse, a blind puncture. I think we really have to use echo there. So you have to get familiar with that, how to see your common femoral artery, your vein. If you would ever doubt on that, typically the artery is easy to detect because it's a more round structure. The vein is typically a bit more elliptical, and if you doubt, you just give a little bit of push on your echo probe, and the vein will typically collapse and the artery not. So it's easy. If you still would doubt, you can put some color on, and then you can see the arterial flow. So this is the classical transversal view, short axis view, which is a good view because that's nice to, you can clearly screen where the bifurcation is also. More and more people also use the longitudinal view, or I do very often, if I use it, a combination of the two, I would say. You can start out with the longitudinal view to try to see if you have a good view there where you can see the bifurcation. You can also nicely, in a nicer way, appreciate there where the artery actually dives. And then if you centralize, for example, if you think you want to puncture exactly there, if you centralize this in your echo probe and then you make a turn, 90-degree turn with your echo probe, you are actually at that spot. Then you can start to get down on centralizing for your puncture site, that you're not at the site of the artery, but that you can have nice indentation on the roof of the artery before actually really going into the artery. So this is a small video. I think it's like 2-3 minutes maybe. So you start here. So this is the echo probe. This is the transversal view. So you see here very nicely, you see it even bouncing, very nice artery. You can immediately also see what is also very important there is that you appreciate how deep your artery is, yes? So here you see it's a skinny patient where the artery is only at 1 centimeter depth. You see that here. That means that I will start to puncture the skin pretty close to my echo probe. Yes. If you have on the other side, and that's what many people don't understand when they start doing echo-guided puncture, if you have an obese patient or a patient with more fatty tissue and the artery is at 4 centimeter depth, you also have to start making your puncture in the skin roughly 4 centimeters away from your echo. And I see making many mistakes to that people, they have a nice echo image, and then they see their artery at 4 centimeter depth, and they make the puncture in the skin at 1 centimeter. Of course, when they come to you make a puncture at 45 degrees, when at the time they're reaching the artery, they're already past the echo beam. Yes, so that's the classical mistake. So it's a lot of information you get out of this echo. You see your depth, and that has consequences where you make your puncture in the skin. So here, echo is also, by the way, really great to make an infiltration with your lidocaine, with your local anesthesia. If you want to optimize your local anesthesia effectiveness, it's better to give this also under echo guidance, because some people I also see giving them their local just blind, and then when they come with the final puncture for the artery, then they use their echo. I would say that's a shame, because on echo you can nicely see the infiltration just above the adventitia. Here you see we had a nice puncture in the middle, and it's almost, I would say it's not mandatory, but it's almost easier if this is an act of two people, where the one guy is holding the echo with the left hand, has the needle on the right hand. He just does everything what he can to really be good. When he sees the tenting on the roof of on the top of the artery, then his second operator or a fellow or a nurse has the wire ready, and as soon as he's in the artery, the wire goes in. Yes, so you don't have, it works really elegantly if you do it that way. So I think that's for the access. Dejan, maybe you want to add on that?
Just a reminder, you can ask the questions anytime you want. You can approach any of the microphones, just raise your hand. And also you can ask the questions through the chat. We see them there. We can address them anytime. I think one of the most important questions here, because you brought it up and you said ultrasound guidance is important. So I would like to know the opinions of Maurizio and Wolfram. What do you think about that? Do you use ultrasound guidance because you think it's almost mandatory if you want to perform suture-mediated closure? Or do you still rely on angio guidance as well?
Well, I totally agree with Ole. I think now is, I would say, almost mandatory to use it. We don't need any specific material. Everyone has a ECMO ultrasound machine in the lab, so we don't need any special tool. Many people think that it's like easy to puncture, but you gain so many information in such a limited amount of time with such a short learning curve that you actually, after 2-3 times, you are already fit in doing it. So I really don't see any reason why not to use it, comparing what you have to invest and what you get back from the information.
Yeah. What do you see as disadvantages of not using ultrasound guidance for the suture mediation?
Well, of course, you need some more radiation, so it's for you and for the patient. I mean, it's not a lot, but if you do many cases every day for many years, you save a lot of radiation. Actually, you can really be in the middle of the artery. You can see the quality of the wall, the calcification pattern. You can avoid the calcification. You can really see the tract when the artery is going down, so to avoid to puncture the tract of the artery which is going down. And so I only see advantage. I don't know if you have any comment.
No, I agree. That's the big difference with echo and fluoro. Of course, you can do fluoro guide. I did it also in the beginning of my career only on that. But radiation is one issue. But calcium, you don't see that easily on fluoro as compared to echo. And then the diving part is indeed a more important part than you think. So on fluoro, also if you do an AP, you don't typically see where that artery dives. You don't see, you cannot appreciate it very easily. You can see that very well, for sure, on the longitudinal view on the echo. Yeah, so there are quite a lot of, or many advantages on using echo, absolutely. Yeah. And the local anesthesia too. I mean, you can really, if you want to do your cases in local anesthesia, as more and more centers want to do their TAVIs in local anesthesia only, as we do in Copenhagen too. I mean, it makes it just better, more effective, your anesthesia, to give it under echo, instead of giving it blind, that's for sure.
So let me just emphasize that before we come. So you said it's important for 2 reasons, and you said 2 points. One point was the diving of the artery. Can you see that actually on angio? If you do the angio guidance, I mean, this is going to be above, it's not going to be seen, yeah? Why is it problematic? So why is it problematic that we put our ProGlide or ProStyle in that part of the artery?
Because then you have much more failure of your suture-based vascular closure device, because you cannot get the anchor nicely against the wall of the, pull back to the wall of the artery. That's the real issue. And that's one of probably, I think, the most frequent causes of failure of a suture-based closure device if you have a failure. Yes.
Okay.
Wolfram? Tilly, some question from the audience. I have a question for you. You told us you would like to avoid the 1 centimeter above the bifurcation. Can you explain it, why you do this?
Yes.
And what do you do when this is the only spot which is calcium-free, this region? Would you still avoid it, or would you make an exception?
No, I would still avoid it. I mean, the whole issue is if you puncture within a centimeter of the femoral bifurcation, that at the end, if you have an issue, and you have to go over to stenting, for example, covered stenting, then you stent over the profunda, for example. Yes. So I would do anything, really anything, to avoid puncturing in that 1 centimeter above or below the femoral bifurcation. And then I will find a spot. Then I even prefer to maybe puncture in the superficial artery, which I've done a couple of times in like very obese patients. You're sometimes forced to go, you cannot reach the common femoral because the patient is such much adipose tissue. So then I prefer even that than puncturing in the place of the very close to the femoral bifurcation. You jeopardize all your chances of bailing out yourself at the end. Yeah.
Okay, let me try. Yeah, let me try to summarize. Yes, please.
There's another question from the audience now. They ask, what's the problem if you puncture in this diving part of the artery? Can you explain it again?
Yes, I will explain. But then maybe again, that's this one. Maybe
I can explain it here, Ole. If you look at the picture here. So what can happen? Yeah, what can happen in the diving part? And please correct me if I'm wrong, of course. But the way I understand it, what can happen in the diving part is this.
Yeah.
So you have the foot, which is not touching the arterial wall. You see here? This is the space between the foot and the arterial wall. Here, the arterial wall is correct. here. You see? That is completely correct, on the arterial wall. However, the foot here does not touch the arterial wall because of the angle. So when you deploy your needles, they're not going to get to it, and you're going to be unsuccessful in tying it. So I think that's one of the points.
Yeah, for that, I think we better move on to the next one, because there we explain how this device actually really works. Because we cannot talk about the foot, or anchor, if we didn't explain what it exactly is. So we come to it. Maybe we should move on.
We move on. Just let me briefly summarize what just was said in 1 minute. So there were, I think, 2 important points. We use CT, and we said, YouTube is not enough. So we need to prepare for vessel closure by knowing the anatomy of the patient. CT scan will tell us at least where the bifurcation is. In this example, the bifurcation is high. It's already at the mid of the femur. And we know that going into the procedure, so we do not have to do any contrast injection. We know that beforehand. We take the ultrasound, and we can, with ultrasound, go just above, a little bit above the bifurcation, and then puncture. The second reason why ultrasound is important is to avoid plaque. Just imagine this. So you place your needle here, and it goes through this plaque. Great. You have some resistance, but it goes. You place the wire, and then you want to deploy your Pro-style device here through that plaque. It's calcified. It could be fibrotic, so you don't even get with the needles through. Or worse, you can even be in dissection over there. So of course, with the ultrasound, you avoid that by finding a spot which can have a plaque here on this side, so that you can safely puncture here, where there is no dead plaque. So that is, I think, how ultrasound guidance really helps if you want to use it, if you want to use the suture-mediated perclosure. But Ole, please maybe continue with the mechanism of deployment.
Yeah, because we don't have that much time. I mean, time runs indeed. And then let me show. So this is about the Pro-style specifically, yes? But it's interesting because if you use a device, maybe before we really let it play, before you use a device, any device, I would say, as an operator, I think it's really smart that you understand fully how this device works. If you understand what it's actually doing when you're moving a certain knob or pulling on a certain knob, make sure that you will get more success, yes? So this is a wet model, just out of the patient, just to let you, this is a video which is a camera which is sitting under here, so that shows you what's happening intravascularly, and see what I'm doing with my hands and how we deploy then the Pro. Oh, sorry, that's already immediately the end that I showed here. Yeah, the wet model. Okay, let it play. So, okay, this is puncture, wire goes in. I hope you can see the videos, we're not in the way. What is important after you made the puncture, that you make a skin incision. Yes, don't forget to make that skin incision, because if you don't do it before you deploy your ProRite, you may also come in problems there. So it's always mandatory that you make a skin incision. After that, after you made your puncture, don't go straight in with your Pro-style. I would not encourage that. It's important that you kind of predilate the trajectory, the channel, with just a 6 French sheet. So that's what we hear here. It's a little bit more resistance than in real life. It's kind of a gummy tissue there, but I'm pulling back now. So it's important you make your skin incision, go in with a 6 French sheet, you keep your wire, you compress on that moment. Then the device will come in. Of course, in real life, you're compressing now in the groin, because otherwise it will bleed. Then you make sure that the wire exits on the side port there, which is, you will see there, the side port is indicated by the white parts here, this here. Then you go in, okay. Okay, wait, oh, okay, the video is still playing there, okay, good. I didn't see that. So we go in until the wire kind of hub, the port where you go in with the wire disappears just under the skin. You pull back on the wire. And now we go in the direction, follow the axis of the artery. I also see some people, young fellows, for example, who do this for the first time. They don't respect the axis of the artery, especially if they're working on the left side. They go in with it like this. No, try to go into the axis, follow the axis of the artery. Then you see a bleed back, yes, on the side there, on the side port. If you see that, you and that's important that you see that. So I brought back I opened up the anchor. Now I pull back so that you have good opposition of the anchor to the vessel wall. Then I make a 45 degree, and now I shoot out my needles. Yes, you see perforating the needles there. There's two needles who perforate actually the vessel wall. Then I bring out the suture, I cut it, and then I bring the foot plate. I go a little bit in, so I come a little bit, take a bit distance from the vessel wall. I bring the foot plate down, so it gets back into my Pro-style, and then I carefully pull it back. Then I have, it's one suture, but it has two ends, the one suture. So I pull that on that one. I already pull it in the direction of the vessel. Yes, so I have the two ends. I pull in the direction of the vessel to get the knot already a little bit down. And then you bring back on the Pro-style until you have the hub, indicated by the white color, to go back in with the wire. Yes, and that's your one Pro-style that you did. Yes, then you can do your second one after this. So then you pull it out. So this is on the wet model. So, and I think, I think I had like a real life. So this is then the suture from inside, how it looks. This is in real life, yes. So let's see this quickly too. So I'll go a little bit forward for the time. Yeah. Okay, good. So we give a little bit of additional local anesthesia. Now the 6 French sheet goes first in to open up for the trajectory here. Then the Pro-style comes in. You see again, we pull back on the wire if it's a short wire until it comes out of the side port. We hold it, we go in. Until it really just disappears, the hub under the skin level. So we go in here in the axis of the vessel again. Yeah, here we go. Here we're just in. Now we pull back on the wire. Yep. And then we introduce it further. I'm working here apparently on the left side of the patient, so which is not my routine. So here you see, then you see the bleed back. Also don't go too deep, because the point is some people go too deep, they see the bleed back, but they keep on going back. If you're then too deep and then you open up your foot plate, your anchor, you may risk to catch calcium further down the road. So it's not the purpose that you see blood back coming back and go even many more centimeters deeper. No, you go advance slowly, and as soon as you see the bleed back on the side, you kind of advance just a couple of millimeters, typically 5 to 10 millimeters maximally, and you stop there. If you doubt how deep you are, it's better to retract again till you don't see any bleeding again, and then you advance slowly, and then from the moment you see bleed back, you advance maximally 10 millimeters. Yes, that's all just to avoid that the foot plate or the anchor, I think the official word is the anchor, that the anchor comes to get entangled or catches some calcium. Yes, and then we pull it back here, and then the wire goes back in. Yes, and we repeat this for the second Pro-style. If you use the second Pro-style, then afterwards we bring in the 6 or the 8 French sheet again, and then we scale up to the introducer sheet we have to use for our TAVI procedure. Yes, so that's basically the deployment of the Pro-style. Okay. And then I think, yeah, there's not much, maybe some questions about this, or it's all crystal clear. I don't know.
Yeah, there's a question here. Can you go to one of the microphones so we can have? It's over there. You can have one here. Can we have the smart screen on? Because that's the key step actually.
Do we have to dilate the track with an artery forceps? Because one of the some of the people kind of recommend that, you know, after you've put in the wire and after you've taken out the sheath, you should kind of remove the subcutaneous tissue with an artery forceps so that the fat and other things get removed from the track.
I never do. Yeah. Okay. And I can tell you it has no impact on the success rate, because the success rate is almost 100%. So it's like, no. I mean, I don't do it. Never. Even in OB, I mean, nothing is against it. So if you feel better to do it a little bit with the forceps to make the channel open, yeah, do it. But I don't think, honestly, it makes any difference. No.
That was, I think, the most important point of the video, which we want to highlight. So if your foot pedals are not here on the wall, if there is this space here, you're not going to be successful in deploying the device. You cannot puncture the arterial wall correctly. And this is how it looks like. Look, this is the needle. That is the needle going through the wall and being anchored on the foot.
So there is typically a feedback well, a tactile feedback when you feel like you have the anchor against but there's also the bleed back. If you pull back on your ProStyle and you think you're with the anchor at the top of the vessel wall, you think that, but you still see a pulsatile bleed back from the side. You're 100% sure not good. And the risk is that if you deploy your needles, that you will have a failure. So it's better not to shoot your needles and bring back down on the anchor and repeat the maneuver again until you have pull back. And with the pull back, you should strictly not see any pulsatile side bleed. If you do this and you deploy, you risk all kinds of complications. Either you have a failure of your device, or in the worst, I've seen this also happening, that you shoot the needles in the posterior wall. Yes, and then you can get some other tricky complications. Yeah.
Yes.
There are two questions. One, again, regarding this descending part of the artery. When it comes to an operation, is it more difficult? That's a question number one. And the second question is, if you use this device, when do you administer heparin? Ole.
Oh, yeah. Well, for the operation, well, to be honest, we never send patients to operation. We always bail out with stents or balloons, and then it doesn't really matter if the puncture is too high so no. And then heparin, yeah, typically my heparin goes in after I've done these maneuvers. So I don't give, but okay, it's not as strict. I don't think there's strict evidence about that, but I typically assure my access, my closure, and then when that's in, then I give the order to give heparin typically. I don't know, maybe there's other approaches. No?
We do actually the same. I think it's important to remember to give heparin before putting the big sheath in.
Yeah.
Then if you do it after the deployment of the two ProStyle or even after the puncture, if the wire goes up, probably it's not so crucial, but we do the same after securing the access, we give heparin.
That's one more time the diving part. I think this was very important. So if we puncture too high, and this is why the preparation is important in the understanding of the baseline anatomy, but also the echocardiographic guidance. You're going to have this problem. You see this space? This is the space between the foot pedal and the arterial wall, which is created by the angle. So if that happens, you're not going to be successful in anchoring the needle on there, and you're going to have the failure of the device. And I think that's the explanation, because this was a repeated question. So that's the explanation why it's important to plan it, because then it's not up to device actually, it's up to us in the planning that we had at the beginning.
No. On fluoroscopy, on echo, yes, but on fluoroscopy, no.
See, on fluoro, it's this.
Well, on the other hand, if you look very much in detail on your CT, what I do, that's why I turn on my CT, I look where my artery dives, and very often, in the majority of cases, classical TAVI patients, it is at the top of the femur head. Yeah. So it's a good thing. You don't want to puncture higher than that anyway, because if you have a complication there, you also risk retroperitoneal bleed and all that kind of complications. But I do actually actively look at it on my CT. Yeah. Oh, yeah. No, but then echo. Yeah. That's why I think really you should question yourself if in contemporary practice for any procedure, I think there's more and more data that if you do echo-guided puncture, you just reduce for anything, even venous puncture. I would strongly advocate to learn it and to apply it in your practice. Yeah. It's worth the investment. There's a small learning curve, but as soon as you do it, you will see your complication rate will go down.
Yep.
Hello. I have a question. Like you said, if you suture the posterior wall, just a complication, just let's imagine, is it possible to use the balloon to rupture these sutures? And after rupturing, of course, we'll have the bleeding and you put the stent graft or something.
Yeah, I've seen it recently, not in my own center, but I've seen it in a transaxillary case where indeed it was the needles were shoot through the posterior wall. Then they had a massive constriction, and indeed it was possible with the balloon to rupture it, and then they put a covered stent. Yeah.
Thank you.
Okay, I think we have limited time still, so let's go for the closure, because we have done everything for the access and the pre-closure, but let's see how to do the closure then. We have 10 minutes left. So, again, a video. So now the introducer sheet is in. I think it's a 14 French or 16 French sheet, I guess, like most. So again, here. So these are the two, you see the two prostyles on both ends. So every prostyle has two ends because it's one suture on the left, one suture on the right. Yes. What I do is I put my forceps on the short end of the wire. You have a longer end and a shorter end. The shorter end has typically a wide end at the end, yes, of the wire. So I put my forceps on the short parts. Then I wrap around the two long ones parts around my finger. Here now, I think the thing is that the dilator will still come in, I guess. Yeah. That you don't have to do that, but these patients are in local anesthesia, so we want to make the transition by pulling out the introducer sheet, have the dilator back in, because then you don't have that big step down where you suddenly start to compress in the groin. You can have a more transient pull out. So here we're ready. So the sheet is there. Now again, somebody should prepare for you wrap these long ends of the wire around your finger, typically your digit finger. Yes. And now we keep, of course, always the wire in. This is a classical J wire, or you can keep a stiff wire in, whatever you want, whatever your strategy will be. But we keep a wire in there, because then we can still either supplement with a third pro style, or we can do something else, like a suture-based closure device, depending if we have some oozing still. So now we're already pulling on both ends, both long ends. Now I drop one of the long ends, one of the pro styles I drop. Now I take the pusher, so I open up. Yes, it's maybe not. Yeah, here that's better to see. I let it slide down, and then it's important that you do this. It's an act with one hand. So you wrap around your digit finger the suture, and then you push with your thumb. So you do this best with one hand. You learn this. I see people also doing this with two hands, yes, that they're pushing and pulling on one. I don't like it that much because you don't have the same tactile feedback and finesse again in the pushing. So it's better to do this. Look here. So you wrap it around your digit, and then from the same hand, you pull on your wire and you push on the knot. You push the knot really down, and you can typically, now it's already quite nice, so it looks already closed. I don't think I have to supplement with anything else. So the wire goes out, and we repeat this on both ends. You see also what I don't do is I didn't pull on the short end of the suture, yes, because you have to know as soon as you pull on the short part, you lock the suture, yes, the knot, yes, you lock the knot, so you cannot further push down. So that's only at the end when the wire is fully out. So now you see I'm pulling also on the short part, on the short end of the suture where my forceps is on. Now I kind of fully lock. I lock the knot, and now the knot will not go further down or up. Yes, I completely sealed it, I locked it. I do with both ends. Yes, so one part, second part. Now I will pull on that short part. So now I'll lock it, and then you're done. Yes. What you can still do then, before that, I sometimes also push on both parts, so not only on the long part. I did it probably before this, so I push on the long one, then I push on the long and the short together, and then I lock my suture, and then you have a almost complete hemostasis, as you see here, in this case after two pro styles. Okay, and then we make a skin suture.
Ole, just one question as we're watching this. Mm-hmm. Do you have an intermediate step sometimes with a 7 or 8 French sheath in so that you can have a visualization of the artery before you close completely? So.
Yeah, we do that nowadays, to be honest. I mean, look, there's many approaches you can do this, but we do that, in fact, to be honest. So you can do your 1 or 2 pro style technique, as we explained. What we do in Copenhagen is that we keep a wire in, and then in order to get a control, I don't like any check from groins from the radial. I mean, first of all, it's very cumbersome. Sometimes you see people giving minutes of fluoro to get down there because it's hard to get there. And then finally, if you're there down and you see an issue, what then to do? I mean, very often people don't have these very long balloons or very long or stents on very long delivery shafts. So I think it's a waste of time really to do a check ever from radial. The better approach is the following: that you go in. Maybe I can. We have like a couple of minutes, yes. So I can make a drawing. I can maybe you can help Dijon with finding an empty slide. Yeah, great. So what we do is at the end, So we close. The 18 French comes out. We close, and then at the end, in the artery, we keep a wire, and we reintroduce just a 6 or an 8 French sheet. Yes, we reintroduce this on this wire, and then typically it's very dry. That's typically a good sign. But then through this 6 French or 8 French sheet, you give your and you can give it very controlled. So it's only 5 cc or so, 5 or 8, maximally 8 cc. You give it controlled through this 6 French sheet. Yes, you give a small angio, and then whatever you see. So if you see typically you see a nice closure, and you're good. Yes, and then you can take everything out and you can lock your sutures. If not, if you see like a very minimal oozing, like really a minimal oozing, then I would say sometimes you can supplement with an angioseal, yes, even with some larger oozing. If it's really more oozing than this, if it's oozing like that, then on that moment, it's better what we do then you supplement with the ProStyle. Like if you started out with 1 ProStyle, you put your second ProStyle there, or if you started out with 2, you can put your third one there. So it's like a stepwise scaling up. And if you have a massive disaster there, like you don't have any closure, you see it's a massive bleeding. There are some reports now. I've done it. I know he reported Mohamed Abdelwahab from Leipzig. He has a series of 60 cases or so where if you have then a full, complete failure here, then it's going to be hard to go starting with suture-based control because you have complete failure, for example. Then you can at that moment go with, for example, a larger, like a Manta, a plug-based as a bailout. Yes, we kind of only use it still as a bailout because then there are techniques to position it. But I think it gives a nice visual assessment of your closure. If you have a perfect closure, good, you're good to go and you can close completely. If you have some minor or moderate oozing, you can supplement with another mechanism like a plug-based on top of your suture-based. And if you have a complete catastrophe, you can consider other tools, either cross over and go for your stenting, or go, if you have a Manta, for example, go out for a Manta bailout.
I think this was an important point. So basically, there is an intermediate step. You put the sheath in and give an ipsilateral injection to see whether you have any complications, and you close around it on the longer part of the suture. You do not lock in, of course. You lock in once you get everything out. That's an important point, I think. But I would like to hear from Wolfram and Maurizio, what are your strategies for contrast? Do you inject contrast at the end before you lock in to have a control? Do you do it from the same side? Do you do it from the other femoral? Do you do it from the radial? What is your strategy?
We always do an injection. Usually we use the same technique that actually I learned from Ole, to homolateral 6 French, and we inject, and then if you are happy, we remove it and we tie it, and we don't do any further injection if this injection was fine. If you are still in doubt of there is still bleeding, I mean, we do a contralateral injection. I think what is important is not leave the room without having been checking with 100% security that there is no bleeding. So if there is a doubt, you can also eventually compress and do it a bit later, or you can even check it if you are really good with ultrasound, if there is some aneurysma spurium. But it's really important to be sure that you leave the room with the problem solved if there is any problem.
Yeah, we do it from the other side, taking the pigtail down.
Routinely?
Yeah, routinely.
Okay. So that's another insight. So there are these two possibilities, but I think taking the last injection is very important. We need to see the anatomy before the final closure. Ole, we have approached.
Yes, I think we almost approached the end. I think it's up to you to make some conclusions, Dejan.
Yes, but before that, we address one more question.
We do not forget the questions. 3 questions.
Okay.
When to use 2 systems? How about checking after closing by echo? And what time after successful large bore closure to ambulate these patients?
Yeah, I will start maybe with the last question. That's not my merit. That's from the nurses. We have a great nursing team in Copenhagen, and what they did is they did even a randomized study and mobilizing them 3 hours or 6 hours after the procedure. And to be honest, I've seen the results. Those results, I don't think they're published yet. Some of the research nurses is working on this, or of the TVT nurses are working on this, but it didn't make any difference. So, and that's only thanks to the rule that you said. I think it's so key that our patient does not leave the lab if we're not 100% sure we have their full hemostasis. I never send a patient out and saying like, yeah, but now, well, I'm kind of doubting, but okay, just compress half an hour. That's not acceptable. So, and then you can mobilize them 3 hours later. That's the question. Answer.
We have only some seconds time. 1 or 2 systems. Do you routinely take 2 systems or only?
It depends.
Exception?
It depends. I mean, that's depending what you're using, how. If you feel extremely safe with your first deployment and you have not a TAVI device which is demanding a very large access, then it could be sufficient with 1. But if you feel insecure or you feel more safe with 2, I think you should go for 2. Yeah.
Checking by echo after closing, it's a topic.
You can do that also. I mean, the only problem is if you do that, I kind of do like it too. I've seen people doing this with good result. Of course, the problem is that if you've taken everything out and you don't have anything left there anymore, and then you check with echo and you see a pseudoaneurysm, or you see some oozing, or like, well, you won't see oozing, but you will see some cavity, or then what then to do? So I still personally like this small. It doesn't cost anything, no effort at all. You have their wire anyway, you have your 6 French sheets, you don't have to unpack anything, you introduce it again, you make a small angio, 5 cc contrast. It gives me that extra security, but I know there's some very, very experienced centers, high volume centers, who don't do it and do the pure echo control at the end, and that's sufficient. I think with increasing experience, you could say it's acceptable to do that. Yeah.
Okay, with that, I think we need to end. 2 messages from my side. First is know the steps of the procedure. It is paramount. And the second is you need to know the anatomy as well. If you prepare well, you're going to ensure the device efficacy and safety. So do not go into failing with the device just because of the anatomy that was not okay for that. You need to prepare. You need to prepare with the CT and with the ultrasound guidance, and then the results will be probably favorable. Thank you very much once again for attending.